HighBridge, a division of Recorded Books, presents The Anatomy of Deception, Conspiracy Theories, Distrust, and Public Health in America by Sara Gorman, read by Jennifer Walden. Author's note on the interviews in this book. As a way of providing more color around the concept of medical mistrust and conspiracy theories, I decided to conduct interviews as part of the work for this book. You will hear descriptions and quotes from them interspersed throughout. It can be difficult to find first-hand accounts of medical mistrust and conspiracy theories, especially in this post-COVID moment. As a general rule, empathy has always been a large part of my approach to my research and writing on topics such as misinformation and science denial, and I wanted to be able to describe people's experiences in a way that was both accurate and demonstrative of the nuances of medical mistrust and belief in conspiracy theories. Drawing listeners into individual stories felt like the best way to ensure that there could be a better understanding of why these attitudes arise, to counteract the too common automatic rejection of people who may hold these beliefs, which damages any attempt to build back trust. The interviews in the book were mostly conducted between January and April of 2022. All participants were asked the same questions, with follow-up questions in certain cases as appropriate. Most interviews lasted between 45 and 60 minutes. The interviews are separate from any work done by my nonprofit research organization, Critica. I sought IRB review from an independent IRB, Salus IRB. Salus IRB determined that IRB approval for this work was unnecessary, as it was not concerned to be contributing to generalized knowledge and did not meet the criteria for human subjects research. Participants were initially recruited via social media, with calls for participation going out on my personal Facebook, LinkedIn, and Twitter accounts. After that, the recruitment method was mostly snowball sampling, in which I asked interviewees to recommend other people I should interview. As detailed in the introduction to this book, there was a wide range of ages, genders, geographic locations, occupations, education, and income levels among the interviewees. Interviewees were promised that names and other identifiable information would not be included in the book. I transcribed notes and specific quotes during the interviews on my personal device. Introduction. In February 2023, I interviewed a woman who had spent upwards of 30 years in the pharmaceutical industry who, between tears, told me that she was afraid of what the COVID-19 vaccine was doing to people. Because she still works in the pharmaceutical industry, she asked me many times to be careful about what I shared about her. Yet in the same breath, she wanted the truth to be known, that pharma companies knew the vaccines were dangerous and pushed them forward regardless. That same day, I spoke to a middle-aged retired steel mill worker with sarcoidosis. He was on disability and Medicaid, and was a far cry from my previous caller's comfortable life in one of the wealthiest neighborhoods in the United States. And yet, his story was much the same. To say that mistrust in healthcare is common in the United States, particularly in the aftermath of the COVID-19 pandemic, is perhaps an understatement. When I recruited interviewees for this book by asking people to contact me if they distrusted medicine and healthcare, I was instantly overwhelmed with replies. It made my mission in this book that much more urgent and relevant. This book examines how we got to this place of widespread mistrust in healthcare, health-related conspiracy theories, and the proliferation of misinformation about every health topic imaginable. But it also tends to the deeper structural issues that drive and exacerbate these problems. Over the course of the coming chapters, I draw a straight line between the structural problem of access to health care and the crisis of trust in local and federal health and public health institutions. Rather than treating lack of access as a public social problem and mistrust as a private psychological factor, I suggest that the two are actually closely aligned, and the relationship between them is dynamic and bidirectional. Access drives trust, and trust also drives access. We need to stop asking the question, what is wrong with people who can't trust the healthcare system? And instead ask, what is the healthcare system doing that is pushing so many people to distrust it? I also examine some of the major macro-social problems in our country right now and suggest that their relationship with the crisis in healthcare is not actually that distant. The sense of isolation and abandonment that ensues from a recognition that the government cannot take care of its own citizens has led to a widespread feeling of disillusionment that has made authoritarian and populist viewpoints more attractive. I argue that the right to health care and a right to well-being are some of the most fundamental rights of any democracy, and the failure of the American healthcare system to protect its citizens has led to a widespread turning away from the very systems that underlie our country's democratic system. As a result, a turn to the far right, with a deepening of despair along the way, often referred to as deaths of despair, can be seen as a turn away from the systems of well-being that have failed so many people. I also conducted over 70 in-depth interviews with people who either expressed high levels of distrust of healthcare or who had a close family member who did. These interviews yielded many important insights, the most important of which is the idea that struggling to access quality healthcare leads to distrust in the medical enterprise, full stop. In making this argument, I am by no means condoning acts of violence and hatred that happen on the far right. There is no excuse for any form of ideology that creates vicious in-groups and out-groups and proposes violence as a solution to societal problems. However, as we are living with the consequences of this widening ideology, I am trying to get to a place of understanding where some of the fuel for this fire is coming from. Perhaps in identifying this fuel, we can also think about a road to reform of some of our social systems that would actually make a difference. In this introduction, I will give a short summary of these themes and then outline the arguments of each ensuing chapter. I will also summarize who was interviewed and some of the emergent patterns from this exercise. Medical mistrust, definitions, prevalence, and equity issues. Traditionally, medical mistrust has mostly been measured as a person's trust or distrust in their direct medical providers. Over the course of the pandemic, the average person's interaction with broader healthcare systems and public health institutions increased as a result of much more frequent and pervasive communication by organizations such as the Centers for Disease Control and Prevention, CDC, with the general public. One of the arguments of this book is that the notion of medical mistrust needs to be updated. It is no longer focused on attitudes toward providers, but includes a much broader sense of trust or distrust in institutions and the systems of health and public health that surround people. The pandemic represented a serious blow to trust in healthcare and public institutions, among both the general public and among clinicians themselves. Over the course of the pandemic, both patients and clinicians developed a greater degree of suspicion about recommendations coming from the government. Some have noted that it can be difficult to build clinician-patient trust when even clinicians don't fully trust the recommendations and the healthcare institutions making them. So in this case, we note a kind of intertwining of the twin challenges of trust in larger healthcare institutions and trust in individual clinicians. Between May and October 2020, trust in the CDC decreased, while trust in other government agencies, FEMA and USPS, increased, even despite recent scandals within the USPS. There were substantial declines in trust in the CDC among those who wanted to vote for Trump in 2020, or who were not voting at all. Trust in public health institutions and trust in science had an important impact on the extent to which people took preventative behaviors during the pandemic, even regardless of political affiliation. For example, 80% of Republicans who trusted science in one survey reported feeling that social distancing was important, versus 55% of Republicans who did not trust science. In 2021, the Social Science Research Center, NORC, at the University of Chicago did a very comprehensive survey of both patients' and clinicians' trust of different components of the healthcare system. Overall, they did find that patients had higher trust of personal clinicians than of any other component of the healthcare system, including the healthcare system as a whole. 64% of patients said they trusted this. Government agencies, 56%. Pharmaceutical companies, 34%. And insurance companies, 33%. There were some interesting differences in the extent to which doctors and members of the general public trusted healthcare institutions. For example, members of the general public say they trust hospitals at a higher rate, 72%, than physicians do, 60%. There was also quite a disparity between the extent to which physicians think patients trusted them, 98%, versus what percentage of the general population said they trust their personal physician, 83%. In general, people's trust in clinicians increases with age and income, but trust is lower among non-white individuals. There were also some important findings in this survey around the relationship between systematic and interpersonal trust and physicians and the public's confidence in the general ability to change health behaviors and maintain adherence to treatment recommendations. There is a general belief in the field of medical mistrust that trust in individual clinicians is higher than trust in the healthcare system, systemic trust, which includes trust in governmental public health agencies that communicate with the public, such as the CDC, and that the two types of trust do not necessarily interact. That is, a person can have extremely low trust in the system, but have a high level of trust in personal clinicians. The consequence of this has in some cases been that many people do not worry too much about low systemic trust because they think interpersonal trust, trust in an individual clinician, will be high enough to result in good treatment and health outcomes. This is wrong in a number of ways, not least of which is the fact that during a public health crisis like a pandemic, much of a person's behavior that will determine both individual and community health outcomes will be preventive and will not involve a personal clinician at all. But one of the other reasons this sentiment is misguided is that, as we can tell from this NORC survey, it probably isn't true that there's no relationship between systemic and interpersonal trust. For example, the NORC survey found that people with a high level of trust in the healthcare system are more likely to say that doctors trust what they say, 87% versus 67%, that doctors spend sufficient time with them, 80% versus 61%, and that doctors care about them, 79% versus 52%. This finding suggests that, contrary to prevailing opinion, it is in fact possible that lower levels of systemic trust may result in an erosion of confidence in a variety of interpersonal factors that may subsequently decrease people's trust in their clinicians as well. It is therefore extremely important that general trust in the healthcare and governmental public health systems be maintained. There is another factor here, the concept of self-efficacy, which is the notion generally describing people's self-confidence in their ability to activate certain behavioral changes. Importantly, physicians tend to overestimate patients' ability to adhere to treatment plans, with 93% of them agreeing that most patients can adhere, versus 81% of patients agreeing with this. In addition, 59% of clinicians believe that patients can make lifestyle changes, while only 49% of patients say the same. As I will argue throughout this book, self-efficacy is not only an important driver of behavioral change, but also a component of trust in government health sources. People with high levels of confidence that they can understand and apply complex health and science information to their own lives generally feel less duped and controlled by government health and science communication. A better and more realistic understanding of patients' self-efficacy among clinicians would be a good place to start in building this skill in the general population. What impact did the pandemic actually have on trust in the healthcare system among both clinicians and the general population? The NORC survey found that there were no major changes in trust in the healthcare system among patients and physicians as a result of the pandemic. For 53% of physicians and 56% of the public, trust levels stayed the same. However, There was still decreased trust among 30% of physicians and 32% of the public, which is not insignificant. A fair number of physicians, 43%, reported a decrease in their trust in government health agencies as a result of the pandemic. On one hand, many doctors previously believed their workplace was supportive. They believed their workplaces offered good access to care and reduced disease transmission. Yet only 75% of physicians thought their workplace supported their well-being during the pandemic. Perhaps not surprisingly, patients identified physicians as trusted partners during the rollout of the COVID-19 vaccine. Asian Americans reported higher levels of confidence in their doctors rolling out the COVID vaccine than other racial and ethnic groups. Democrat respondents were 1.5 times more likely than Republicans to report confidence in their doctor to administer the COVID vaccine. The impacts of COVID-19 on patient and physician trust remain to be fully identified. Yet it is fair to say that the contact that the average American had with the public health system and governmental institutions that plan for and run responses to disease threats increased during the pandemic. This exposure resulted in more reflection on trust in system-level actors in the healthcare system, which has become an increasingly important component of how people think and make decisions about individual health. The trust literature importantly focuses a good deal of attention on how levels of trust, both systemic and individual, differ across racial and ethnic groups. As Bogart and colleagues have argued, mistrust has been conceptualized as a form of coping that fulfills epistemic, desire to understand, existential, desire to control, and social, desire to maintain a positive view of self or one's in-group. Motivations under a state of uncertainty, such as COVID-19, and in the face of continued threat, such as discrimination. In this formulation, mistrust can be seen as a response to a negative set of circumstances, such as the uncertainty caused by a pandemic or the everyday experience of discrimination faced by many people of color in the United States and elsewhere. It is, in this way, a coping mechanism. Learning not to trust authority figures and systems helps people shield themselves from the potential impacts of discrimination and exclusion. By shunning the system that oppresses them, people feel less beholden and less affected by subsequent discrimination and mistreatment. As a result, we might expect to see higher levels of mistrust among underserved and excluded populations. In this case, Bogart and colleagues' study looked at a convenience sample of Black Americans living with HIV. They assessed general COVID mistrust and associations between mistrust and COVID-19 treatment behaviors, and future vaccine hesitancy attitudes and behavioral intentions. The study found that 97% of subjects endorsed at least one mistrust belief. The most prevalent mistrust belief had to do with the government withholding information about COVID-19. More than half of participants expressed hesitancy around future vaccination and treatment, and 1/3 said they would definitely not get vaccinated against or treated for COVID-19. In general, only 1/5 of respondents said Black people could trust clinicians, although 3/4 noted that individual clinicians usually have their best interest in mind. Bogart and colleagues also found lower levels of trust, higher rates of vaccine hesitancy, and reluctance to get treated among people with less education. The pandemic brutally exposed the extent of the disparities that exist in delivery and receipt of healthcare services in the United States. The idea that Black and Latinx Americans, especially Black Americans, distrust the healthcare system is ubiquitous throughout the literature on medical mistrust and has become a staple of most studies of vaccine hesitancy. The narrative usually goes that because Black people especially were subject to horrible mistreatment by the healthcare and public health systems in the past, the most egregious and infamous example being the Tuskegee syphilis study. They have in some ways compensated for the harsh realities of this history by refusing to trust the healthcare system or any individual within it. Of course, there are many problems with this account. For one thing, And as I will argue further in Chapter 2, most Black people do not think consistently about the Tuskegee syphilis study or any other awful experiment in American history as a way to make sense of their feelings of trust or distrust around clinicians and the healthcare system. There is an everyday experience of racism and discrimination that many Black and Latinx citizens experience that contribute strongly to feelings of distrust. Furthermore, the notion that hesitancy is based only on historically motivated distrust is not entirely true in these populations and places too much of the onus on victims to get over it. While historical racism is clearly an important factor here, it must be understood in the context of continuing, contemporary forms of discrimination and racism that continue to sow distrust. In addition, types of distrust are too often conflated across populations. Chapter 2 will study at length the differences in the types of distrust felt by predominantly Black and predominantly Latinx populations. The drivers and sequelae of these different types of mistrust are not exactly the same and should not be discussed in the same breath. The idea that we can apply a one-size-fits-all solution to distrust across such varying populations is a mistake and can only fail. There is another significant type of identity that intersects with medical mistrust that I have not mentioned yet, but is probably at the forefront of many people's minds as they listen to this: political identity. While I am not a political scientist and cannot claim to analyze the current political situation with any kind of authority, given the unfolding of events especially over the past few years, and the intense politicization of health issues such as the COVID-19 pandemic, I have found it necessary to comment on politics and political identity in various places throughout this book. That disclaimer aside, it is important to recognize that the relationship between political partisanship and medical mistrust and associated correlates, such as vaccine hesitancy, is not always so straightforward. A clever study by Choi and Fox looked at relationships among public health institution trust, political partisanship, as measured by degree of trust in Donald Trump, and vaccine hesitancy. As the authors note, there are basically two hypotheses about how partisanship aligns with vaccine hesitancy. One is that there is something about partisanship per se that causes vaccine hesitancy. This is also known as the exogenous hypothesis. The other is that there are outside factors that correlate with partisanship, such as distrust in government, that are the true cause of higher rates of hesitancy among members of particular parties. Distrust in government and certain personality characteristics may be associated with both conservative party identification and vaccine hesitancy. In their study, Choi and Fox found that distrust in public health institutions, and by extension the government, was a much greater predictor of vaccine hesitancy than partisanship as a concept. This is not entirely surprising, as many studies have shown the influence of distrust in government on vaccine hesitancy even before the pandemic. In this study, Choi and Fox found that distrust in public health institutions was indeed a much stronger predictor of vaccine hesitancy than either trust in Trump or self-proclaimed party membership. While it's true that when science is unclear, people tend to fall back on their political worldviews, the underlying level of distrust still played an important role in determining certain kinds of health behaviors. While people with low levels of trust in public health institutions claimed holding those views for a long time, even before the pandemic, there were still high levels of trust in personal clinicians in this group. In this study, among those who had low levels of trust in public health institutions, only 49% were vaccinated, regardless of their feelings about Trump specifically. However, among those who had low trust in public health institutions, those who had high levels of trust in Trump had even lower rates of vaccination, 41%, versus those who said they did not trust him, 56%. In this study, demographic factors had less of an impact on vaccine hesitancy than levels of trust in public health institutions, suggesting that in some cases we might be focusing on the wrong factors in the battle against vaccine hesitancy and refusal, at least in the case of COVID-19 vaccines. A large proportion of people who said they mistrusted public health institutions but trusted Trump had confidence in their personal physicians. A substantially lower number who distrusted both public health institutions and Trump had high levels of trust in their personal physicians. Those who mistrust public health institutions reported having low levels of trust in local and national newspapers, but had higher self-proclaimed trust in social media than those with higher levels of trust in public health institutions. The likelihood of at least one vaccine dose among those who had trust in public health institutions and mistrust in Trump was 90%, versus only 43% among those with low trust in public health institutions and high trust in Trump. What is the overall lesson here? To be certain, vaccine hesitancy refers to a complex conglomeration of attitudes and likely behaviors that cannot be attributed to one motivation or driver. However, it does seem to be the case that trust, specifically the more global, government-level trust in public health institutions, has an important role to play here. While many book-length projects have treated the issue of trust in health and medicine, the tendency has overwhelmingly been to focus almost exclusively on the clinician-patient relationship, with particular attention to doctors. There has been some great literature written on the more systemic level of health-related mistrust in certain demographic groups, particularly among Black Americans, best encapsulated in Harriet Washington's seminal work, Medical Apartheid, to which I will be returning extensively in Chapter 2. But in this day and age, in the wake of COVID, a new level and threat of political violence and instability, and a right-wing media empire that sows the seeds of conspiracy theories in an alarmingly large number of American citizens, it felt like the right time to pursue a wide-ranging project that focuses not only on systemic mistrust in public health institutions, but also on the impact of the broader mistrust both in the government and in each other on Americans' desire and ability to seek out and procure quality health care. Throw in the backdrop of a population beleaguered with outrageous medical bills and poor access to even the most basic levels of medically necessary and preventative care, and we have the perfect conditions to study the intertwining phenomena of access, trust, and conspiracy beliefs that now define not only our medical and healthcare system, but for many of us, our everyday lives. The twin healthcare crisis, access, and mistrust. It is fairly well known by now that the United States ranks surprisingly low among developed nations for general health outcomes, coupled with exorbitantly high costs. The COVID-19 pandemic also highlighted another major problem with the U.S. healthcare system: inequities and disparities in access and care. As of a survey done in 2021, 9.2%, or 30 million Americans, did not have health insurance. 30.1% of Hispanic adults and 14.1% of non-Hispanic Black adults do not have health insurance, compared to 8.7% of non-Hispanic white people. While these statistics point to both a global issue of lack of good access to health care, particularly among Black and Hispanic adults in the United States, it does not tell the whole story of how lack of access drives all of the potentially dangerous attitudes and behaviors discussed in this book. From mistrust to conspiracy theories, to vaccine hesitancy and lack of compliance with other public health safety measures. In preparation for writing this book, I interviewed dozens of people who were, or had relatives who were, highly distrustful of medicine and healthcare, or who held actual conspiracy beliefs about the healthcare system, or both, which did occur in many cases. These interviews, which I will pull from throughout the book, nudged me toward one resounding conclusion. It is poor access to healthcare that primarily drives mistrust. As people try but fail to get the healthcare they need, they often turn in their abandonment to alternative treatments and viewpoints. They become suspicious of a system that does not let them in. The same thing can be said on a much wider scale about the government's abandonment of so many people by failing to provide an adequate social safety net, which includes universal access to quality health care.
Sample complete. Ready to continue?